Right, so good afternoon, and thank you for joining us today. We are delighted to have Dr. Stephanie Christenson coming from UCSF. She is a thought leader in COPD, and we're really excited to hear a little bit more about endotyping in COPD and hear a little bit more from her experience and work. She completed her medical degree from the Medical College of Wisconsin and went on to do her residency at Boston Medical Center. And then she went to UCSF for her fellowship, where she has been since after completing her fellowship. She also completed a master's in clinical investigation. And a lot of her work has focused on understanding some of the pathways that are associated with COPD using transcriptomics. And a lot of those insights have been published in very high impact manuscripts in New England Journal of Medicine, American Journal of Respiratory Critical Care Medicine. And we're really excited to hear a little bit more about, it's something that is expanding very quickly on how we approach biomarkers and endotypes of COPD. So welcome.
Thank you. Thank you for having me. Right. This guy. So as he said, we're going to be talking about endotyping in COPD. And these are my exposures. I actually work a lot with a bunch of the companies around COPD, particularly COPD biologics or the new therapies, mostly because I do endotyping, and I'm actually very interested in which groups to target with our therapies. So it's been kind of a fun evolution to try to see if we can get the correct drugs to the correct patients. All right. So we are going to talk about endotyping and phenotyping in COPD, a little bit of background on that, and airway inflammation in COPD and the role of the blood eosinophil, everybody's favorite and least favorite biomarker. And then I'm going to talk a little bit about some of our omics work on airway samples. We work mostly with airway samples as kind of, site of disease for in particular COPD. I do a little bit in asthma. And kind of how that's kind of helped us characterize type 2 biology a little better. And then finally, I'm going to talk a little bit about work on biologics in COPD, where I've either been kind of on some of these papers or advised some of these groups. And so we can kind of talk about our current, like what's here now and what's maybe down the pipeline for COPD. Because actually a lot of things are right now in phase 3 trials. So we think we're going to actually have a lot of new data and maybe new therapies in COPD in the very near future. All right. So first off, I think, how we thought about COPD has certainly evolved in the past several years, in particular that we really think of COPD now kind of, in terms of a lot more than just smoking. And in fact, the gold definition now doesn't even have the word smoking in it anymore. So meaning that we think of this kind of in terms of not just tobacco smoke, but that there's actually a lot of complex gene by environment interactions that really go into COPD, to the point that, we certainly have a lot of patients who get COPD because they are they're exposed to things like biomass fuels, secondhand smoke, other air pollution, maybe viruses, either in childhood or even adulthood, and other external and social factors that may really contribute to their disease, how they get disease, and how they present their disease. Because I think we really know that COPD is really just kind of a grab bag of many different, potentially many different entities, or at least a lot of different biology. So certainly how our group at UCSF, and I know how a lot of groups now are thinking about COPD, is certainly, we know that there's a lot of clinical phenotypes. We already, we saw the pink puffer and the blue bloater in our netter, and so chronic bronchitis and emphysema. We know that those patients exist, but really, when we talk about how do we treat these patients, there's actually a lot of things that we're looking at, differences in our patients, and a lot of these are overlapping, like patients who really have rapidly declining lung function, or maybe they have an asthma-like phenotype, or a lot of vascular disease, pulmonary hypertension, the exacerbation-prone group who just continues to get exacerbations one on top of the other. And I think, unfortunately, like when you just think about it via clinical phenotypes, we oftentimes, we just haven't made a ton of headway by just thinking of it as far as the clinical phenotypes, as far as finding new treatments. So certainly the way I think about it, and I think the way, precision medicine thinks about many things is, hey, what are the molecular phenotypes, or when you're considering a treatment, the endotype, so the underlying biology. And the reason we think about that is because there's targeted therapies for some of these things. And so I pulled up a few things in this slide: mucus abnormalities, type 2 inflammation, et cetera, because we actually have therapies for those things. So you can actually direct something towards those things. And so that's why we're particularly interested in some of those things, whereas, if we can find, so any biology that we can find that we can actually treat is what I'm particularly interested in, because that's what affects my patients. Okay, so when thinking about airway immunology, I'm not going to go through all of airway disease immunology, and I will save you that lecture. But, I think we always think of, COPD is really a disease of type 1 and type 3 type inflammation, that we've gotten kind of these neutrophilic macrophage-driven responses, interferon, TNF alpha, IL-17, that are kind of driving the majority of the disease. But I think what's been exciting with the biologics and what we're understanding is that probably many of these patients, many more than I certainly thought, probably have type 2 disease, so that, just like in asthma, that type 2 inflammation may be driving some of their disease. And I think, when I think about type 2, type 2 disease, I really like to think of it in terms of, well, what can we actually target here? Because that kind of helps me think biologically about what's important. And so if you think about like type 2 inflammation, or even more inflammation more broadly, so we start from the top, where we think of, the epithelium as one of the major sites of disease for COPD. It's certainly causing, or it certainly is very affected by smoking, especially in those small airways where that particulate matter lodges. And, when you get injury to those airways, and similar to a lot of what we've learned about type 2 inflammation is really from asthma, but similar to asthma, you get some sort of injury, insult to those airways, like a microbe hits it, or a particulate, and that's going to cause injury and release the alarmins. So the alarmins being cytokines that are just kind of hanging out in the epithelium. They hang out in other places too, but we'll simplify here. But hanging out in those epithelial cells, just ready to be released. So the big ones that we think about, particularly in COPD, but in asthma too, are IL-33 and TSLP, and as causing kind of some of the major downstream effects. More preclinical models than anything else really shows that probably these alarmins, particularly IL-33, may affect more than just type 2 inflammation. And that's one of the reasons IL-33 has been particularly thought about in COPD, and why there's phase 3 trials in it. And we'll kind of look through some of that data. And so once they're released, then it just kind of starts that downstream cascade of type 2 inflammation, releasing, from ILC2s and T cells that become Th2 cells, the major 3 type 2 cytokines, IL-4 and 13, and IL-5. IL-5 we think of it a little bit differently in that it's particularly eosinophil related, so really drives eosinophil activation in the bone marrow, as well as eosinophil trafficking to the airways, whereas IL-14 or IL-4 and IL-13 kind of are associated with maybe a slightly broader Th2 effect, where IL-4 is related to macrophage class switching, is also eosinophil trafficking to tissues, that kind of B cell switching, so that you get IgE production, and IL-13 really working kind of directly on the airways, kind of directly contributing to airway remodeling, so things like mucus metaplasia. Now, I will say that as much as we like to bin things All of this is actually complex because eosinophils like feedback on the whole system and can cause more type 2 inflammation, more release of IL-4 and IL-13, and IL-4 and IL-13 can feedback on Th2 cells and cause more. So there's a lot of feedback in these systems. So thinking one thing causes this and one thing causes that is probably a little naive, but I think we certainly know that those are the kind of major effects. And the reason that's important is because we really think, okay, those are the things I can target. And it's more than just the eosinophil. So there's more than just the eosinophil to a type 2 inflammation. But it's actually not the worst biomarker. It's also not the greatest biomarker, but certainly we know actually that there's been many studies now showing that eosinophils really are good beyond the biologics for kind of telling us how to use inhaled corticosteroids in COPD. And there's been many studies of this that, hey, if you have elevated eosinophils, all the secondary studies or the secondary analyses of the ICS-LAVA, so the dual therapies, or the triple therapies, as I'm showing here, impact an ethos, where you're using an inhaled corticosteroid, long-acting antimuscarinic and long-acting beta agonist, that the more eosinophils you have, the more likely you are to respond to inhaled corticosteroids. But I think what's kind of interesting about this data is it's not just dichotomous. It's not just do you have high versus low. We actually are probably finding kind of subgroups in this, in that, the impact data actually really starts to separate out. So this is actually a LAMA, this green line. So you have increasing exacerbations kind of as we are getting to EOs greater than 150. And that kind of even separates out further as you go higher. We're kind of seeing that same kind of effect in ethos. And really that group less than 100, this group, they really don't seem to have any effect, right, with an inhaled corticosteroid. And I think that's one group that we really kind of think about, well, not only do you, maybe that not only do you not have an effect, but it might actually cause harm. And so maybe it's not even just like, oh, they don't have type 2 inflammation, but maybe they have different types of, it's a different endotype in itself. I will say that, and this is why I check eosinophils a lot in my patients, and I'm always surprised at who all has elevated EOs. And if you ask the pharma companies like how many people have elevated EOs, they'll say up to 40%. And I will say that I think even if you're looking at the right patient population, an exacerbation-prone patient population, where I'd be considering things like adding inhaled steroids, you really do see EOs greater than in most of these studies, and even in retrospective studies, you see EOs greater than 300 in maybe 30% to 40% of patients. So at least some point, I will say I checked more than once, but we do see actually that it may actually be particularly useful, even in somebody who I'm like, there's no way, and they've got emphysema and maybe chronic bronchitis. And some of these patients I've actually started on drugs, and they actually do better. So I am checking it in a lot of my patients. And this is just kind of a schematic kind of showing that kind of, this is from one of Dave Singh's reviews, but really that low eosinophil group is probably important, and the high eosinophil group is probably important. So when I'm thinking about like who am I really not going to start on a drug versus who am I going to start? Because I think actually some of these studies are really showing us, hey, there's maybe a mortality benefit to inhaled corticosteroids and COPD. So I really want to be thinking carefully about the people I'm not starting on the drug, especially if you're exacerbation prone. But I think we all know that the blood eosinophil is not always exactly predictive of what is happening in the airways. And I think this is one of the reasons we really try to study the disease at the level of the airways. And this is some data from Spiromics, where we just looked at, we have sputum, was the nice thing about Spiromics. So Spiromics is a big COPD cohort where we have about 3,000 participants, smokers with and without COPD, and healthy controls that have now been followed. Oh man, I think we're on year 7 or 8 now. But this is data from their first visit, and really showing that there is correlation between sputum and blood eosinophils, but it is not wonderful. cloud. Like it actually looks kind of a little bit like a cloud. And it was really in this study, and it just depends on the study you look at, but this is a cohort study where we're looking across all comers, and it was sputum eosinophils that were associated with exacerbations, while blood eosinophils actually weren't in this study. Other studies they are, it depends on which group you're looking at, but it does make us go, hey, well, maybe the biomarkers, it's better to be looking at the biomarkers at the level of the lung, especially if we're trying to understand more about type 2 inflammation. Sure. Staying within good time. So some of the things that we really do in our group is look at different types of inflammatory responses based on your gene expression. So this is work that Dr. and John Fahey started doing in asthma many years ago, and we moved it into COPD several years ago, although we've been honing these over the years to try to really understand kind of the best response, kind of the best type 2 biomarker of response in the airways. And I will talk more about how we do this in our research talk tomorrow, so I won't bore everybody with all the omics side of this, but what I will say is that we really start with a bunch of candidate genes, usually from like type 2 high asthma, where we know this person's really definitely type 2 high. And then we do a lot of kind of training in some of our COPD data sets. And eventually we end up with kind of one biomarker of genes that kind of all go in the same direction, and you can kind of collapse into one metric. And the reason we don't use one gene is because those things are really noisy. So a cytokine kind of comes in and out of the airways. It might not be present in somebody's airways. It might be expressed at low levels. So having kind of the group all together is really also how we do pathway analyses. But basically, in the end, you end up with a biomarker. It's not all that, in the end, it's not all that hard. It's one single gene or one single metric. But we can use that metric as a tool to kind of better study on with a higher resolution, what's happening in the airways in some of these big cohort studies where we have a ton of clinical data and a lot of other imaging data, phenotyping data, omics data. So this is just kind of one of our things, and some of this work was done by a medical student who's now one of our fellows, who's been working with Prescott and I for years, and is now working in another asthma lab at UCSF. So, but basically, and I'll show you kind of how we also test these markers pharmacogenomically tomorrow. But this type 2 biomarker, we can first kind of give it make sure it passes the SID test as it related to other biomarkers of type 2-ness. And it's related to sputum eosinophils and related to blood eosinophils, but we all know that those are imperfect markers. So it actually, the higher you are, the more related, whereas kind of the resolution is a little bit lower at the lower levels. But we can see, actually, so there is really a clinical phenotype that it's associated with, and it's not a super shocking or like surprising group of people that we can really see that it's related to people who are more symptomatic. So higher CAT score or COPD assessment test score, have more chronic bronchitis on their SGRQ, their St. George's Respiratory Questionnaire, and actually have a worse 6-minute walk distance. So they're actually like patients who seem to be doing worse clinically based on symptoms. The other kind of interesting thing about this biomarker, this is from data from a while ago that we, so we can use these. So that was data from spiromics, but we can use these biomarkers now once we develop them across like many cohorts where we have gene expression data. And so this is from a cohort from the Netherlands where they actually brought patients, got airway epithelial gene expression in these patients, and then they actually followed them out over 30 months in a clinical trial where they gave them inhaled steroids or placebo. And actually what we saw was that, hey, if you had a type 2 high inflammatory phenotype at baseline, we actually didn't see an association with improved response to FEV1, but we saw a really improved metrics of gas trapping. So RV over TLC and inspiratory capacity improved over time. So basically like the higher your T2 score, if you got an inhaled corticosteroid, that did better. And so it's kind of interesting, as we think of asthma versus COPD, and think of COPD as more of a disease of the small airways. Of course, we all know there's heterogeneity, and there's patients who have large airway issues, but kind of a more small airway disease, seeing this kind of response in relation to the biology in these in the small airways. That's kind of an interesting like clinical phenotype that I wasn't completely expecting. I was thinking maybe it would look more like asthma, but we're really seeing more of a small airway response. And I think that's important because actually that small airway disease and having gas trapping, it really is associated with worse symptoms. So those are the patients who are the most dyspneic. Granted, emphysema also makes you very dyspneic, but having a lot of hyperinflation can make you really feel poorly. I'm going to go a little bit more into this tomorrow, but we also look at the mucins in particular, because mucus hypersecretion is incredibly important in COPD, as in many airway diseases. And we can kind of study this in a more with more resolution. And so here, looking at our type 2 scores, we can look at it in relation to one of our pathologic mucins, or the major pathologic mucin, MUC5AC, and look at the association. We can see our type 2 signature is associated with MUC5AC. And interesting, because actually smoking really causes an increase in MUC5AC. And so we think of like mucus hypersecretion in these patients and chronic bronchitis in these patients. And is it all smoking related? But here we can kind of tease out that we're seeing actually responses that are associated with our type 2 signature, even when we correct for smoking status. And in fact, even when I correct, we use these big, large single cell repositories where I will actually correct for like percentages of goblet cells and other epithelial cell types to see, okay, we're actually seeing an association beyond just a cell type issue and beyond just smoking, that we can see, hey, maybe this is one of the pathologic causes. Now, mucus, when we think about mucus in the airways, and this is obviously, there's a big story around this in asthma, but there's somewhat of a story about this in COPD too. Thinking about mucus as more than just causing chronic bronchitis. So in COPD, we always worry about, okay, if you're getting, and particularly in more severe disease, that not only might you be getting a bunch of mucus production and then getting coughing up a lot of mucus, but that it could also be related to issues of dyspnea and hyperinflation, because it's plugging up those airways. And this is actually work, Eleanor Dunnican, and John Fahey led this work at UCSF. I was just a co-author, but this is from spiromics data as well, where they showed, mucus plugging in some of these groups. And that was really associated beyond just emphysema with having worse lung function and actually just having more severe disease, more decreased oxygenation. So not just necessarily a disease of, not just necessarily a disease that's associated with chronic bronchitis. In fact, mucus plugging was only associated with chronic bronchitis symptoms in the former smokers, and was actually chronic bronchitis symptoms were poorly sensitive specific, only moderately specific for mucus plugging in this group. So just thinking about, mucus is probably actually contributing to symptoms in COPD patients in a lot of different ways. And so kind of understanding like how do we target that, and maybe are there certain patients who've got type 2 inflammation where we can target that? Are there other sort of things that we can be targeting, that can really help with some of that pathology? Okay. This was just one other piece just to show you kind of, there's probably, when we talk about type 2 biology in the airways, particularly in asthma, there's been a lot of talk about, certainly there's the more allergic type 2 phenotype and the more eosinophilic type 2 phenotype. We know those patients look different. Some are like, more classically the child with asthma and allergic inflammation. But this is actually work from Niro Pucha's group and Nadia Hansel, where they actually showed that in COPD, they found that there was this group of COPD patients, and they did not have to be eosinophil high, who seemed to be they had allergen sensitization, and then they went into their houses and collected all the dust from their vacuums and found people that were exposed. So it was actually the people that were both allergen sensitized and exposed those people had worse outcomes. So it wasn't just, okay, you have to have, like in a asthma patient, just allergen sensitization, but these people who were allergen sensitized and exposed seemed to really have worse outcomes, that it was more exacerbations, worse SGRQ, worse MMRC, lower lung function, and particularly in the group that was more severe, who had more severe disease. And this is interesting because we're actually starting a clinical trial based on this with the NIAID called COPD-OMA. God help us, we're collecting dust from all these people and doing allergen studies, and then we're going to, we're getting nasal swabs in all of these patients and to try to see if we can understand some of their type 2 inflammation better, and doing sequencing in these patients, try to understand their type 2 inflammation better and who actually is going to have a response to some of these drugs. All right, and so kind of the, just speaking more about the response, so there's certainly potentially different types of type 2 inflammation, but then there's other types of inflammation in those airways, particularly in a COPD patient, where, we may be thinking, okay, is the patient not responding because they don't have any inflammation in the lungs? Are they not responding because it's not, we're targeting the wrong thing? And I think in some cases it might be one, and in some cases it might be the other. So this is some of our work from a few years ago, really. A few years ago we did some work on IL-17 related inflammation in the lung, and we certainly know type 3 inflammation related to neutrophilic inflammation, lymphoid aggregates, and emphysema. So there's definitely a lot of information and a lot of thought that IL-17 probably contributes quite substantially to COPD pathogenesis, and just understanding who are these people. And we did kind of a similar analysis where we generated these gene expression signatures. I will again go a little bit more deeply into that tomorrow, but where we kind of developed, instead of a type 2 signature, more of an IL-17 signature, and looked at these in some of our cohorts. And in this case, we see associations with neutrophils and macrophages, so it tracks. It's doing what we think it's supposed to be doing. It's tracking with the other biomarkers. But kind of one of the really interesting things about this was that we actually saw that there was an association, actually in FEV1 in particular, that if you had a high IL-17 score, that those patients were more likely to have a lack of response to inhaled corticosteroid over time. And it's, did I not put it in here? Let's see. Okay. And it was actually, you can't really, I don't know that this shows it very well, but they had a lack of response in their to inhaled corticosteroids, and it was not mediated by just those patients had higher type 2 scores or had higher eosinophils in their lungs. That was just a group that was T2 high. And that's why we're seeing, or the group that was IL-17 low was T2 high, and vice versa. It was actually, it seemed to be irrespective. So again, I think to me this kind of means, or I think of this as hey, maybe this is a, either potentially a different endotype, or at the very least, potentially a group of patients where, hey, maybe, if they're not responding, it's because they got a different type of inflammation in their airways. And either we have to target that type of inflammation, or considering IL-17 inflammation may actually be associated with a response to bacteria, and we don't want to target that, but maybe we want to target something else like microbial dysbiosis. So thinking about, this is a patient population that's not going to respond to a steroid, is there something else we should be targeting? And kind of finally on the endotyping response kind of track, I will say we've also spent some time really thinking about acute exacerbations, because now you're adding actually an additional layer of heterogeneity here, that not only do you have all this underlying inflammatory heterogeneity in your airways, but now you're layering on the fact that maybe you got it from a virus, from a bacteria, from I live in California, so from wildfires, but you're getting it from, it's potentially a heterogeneous source. So, there's been already work from Mona Bafadel's group about that we probably have these different endotypes of exacerbations, where you've got T2 related, type 1 related, kind of more pro-inflammatory groups, and then more that are just don't have any inflammation. And so we've kind of done a little bit of work on this related where we've used metatranscriptomics. And this is really work from that was led by Arctic Sarma, who's was one of my trainees, now does actually mostly ARDS work, but still works with me a little bit on COPD exacerbations. And we actually got these samples from the Netherlands that they had for like many years, just like sitting in storage, where they had actually done this study in these patients where they collected samples, sputum samples at baseline and during their exacerbations. So we had both baseline and exacerbation samples in all of these patients. And so we kind of looked at them in two different ways. First, looking at them where we could actually take their metatranscriptome, so meaning basically I can do RNA sequencing with all these patients. And what we can do is we can take, so we got all of their host, all of their human RNA, and we can actually subtract it all out. It's a whole process. We'll talk about it tomorrow. But you know, originally when we were doing this, we were getting all these like gorilla reads and all these weird, like, it turns out we weren't extracting everything appropriately. But eventually, once you extract and take out all the host reads, you can see, hey, what's left. So you can see viruses, you can see bacteria. And so we can type people in this way. We also had eosinophils in all of these patients until we could see who had increases in their eosinophils. And I will say, kind of in this way, we were Arctic was able to actually type people based on their exacerbations. So a small subgroup, but you know, we have 7 who had increases in their eosinophils, 7 who had viruses that we found, 6 who had increases in pathogenic bacteria. So from baseline, where they had increases, which was a nice thing about doing a longitudinal study. But there was actually a lot of people who didn't have any of that, and some of that could be, you know, we think. Certainly there could be issues with the task, but there's also issues with a COPD patient oftentimes does not get their exacerbation symptoms until like 10 days out. That's been shown in like rhinovirus human studies where you get an insult and then it's not until 10 days out that you actually start revving up your symptoms. So you may not see some of these things at the time of exacerbation. But then we can actually look at some of this and like look at what's happening at the level of their gene expression. And fortunately, like you get a lot of the host expression that looks like it should. That we'll get the eosinophil people like seem to have an increase in their type 2 markers. The viral will get a huge interferon response, whereas the bacterial group actually seems to be lower in general and everything. This is where the longitudinal sampling actually really helps because when you look at them versus baseline, it's not that they're low, they're not immunosuppressed. So they just don't get as high of a response as the other people. So you actually do get a really big like IL-1 beta going up and interferon. So we actually do really see a big host response. But kind of an interesting way that, or it helps us kind of like tease out some of that inflammatory response that's happening. But he also went back and kind of did this in a different way where we just looked at the host data because we were like, hey, we don't actually have all the, we're not capturing all the exacerbations here. So can we capture them if we just look at the host data? So he actually went back and did k-means clustering, and he did this in this data set and found these 3 kind of robust clusters. But there was actually a publicly available GSK data set where he was actually also able to find like almost completely reproducible clustering. And it didn't seem to just be that it was like a cell type thing that you would be able to just identify this because somebody's got higher macrophages. It seemed to be that there were these 3 clusters of patients. And again, we'll talk a little bit more about this tomorrow, but we found that really looking at these both based on their exacerbation data and their baseline data, that we found like a lot of different kind of interesting observations. One being that one of these seems to be like this kind of more T1 response, but very pro-inflammatory, not just like a straight up interferon response, but we get a kind of a subacute and acute inflammatory response, and it included 2/3 of the people who got microbial precipitants. There was one that seemed a lot more T2 inflammatory, big M2 macrophage polarization responses. And then there was one that really seemed to be pretty immunosuppressed, meaning that didn't just look like that they didn't have inflammation at all. It actually looked like they had kind of a coordinated decreased response. And that group they're at baseline, they also had that. So they looked like they had a different susceptibility, and whereas the T2 inflammatory group actually looked like they had high interferons at baseline. So I think we were getting kind of these different group responses and different susceptibility responses, so that we have differences in exacerbations and differences in the susceptibility to these types of exacerbations. So potentially helpful, not just in looking at the exacerbation, but potentially at preventative treatments. Okay, and so in the last kind of little part of my discussion here, I was just going to talk about the biologics, and that's because I work a lot with the companies on the biologics. So I think it's an important kind of, as we think about endotyping and COPD and where is this going, and I like to think of it in terms of the biology that we've been studying. And so one of the reasons this is important is that there's a lot of patients, even when they get absolutely perfect triple therapy, that are still exacerbating. And I think we all, that's the group where like, what do we do with these people? And I will say it was even in the IMPACT study, there's 48% of the participants still had an exacerbation over the next year, despite being on triple therapy. So it is like an important group of people. And even when we look at retrospective database data, that you still see that. So let's see here. So, dupilumab was just added to the GOLD recommendations this year as something to add on for a patient group who's got eosinophils greater than 300 after you have certainly ensured that you have optimized them in other ways. So making sure they're on optimized inhaler therapy. And did you check to make sure they're actually taking their inhaler therapy? And are they taking it correctly? Did they get pulmonary rehab? So I am checking some of these other things. But we have certainly, it's exciting for us as the first biologic in COPD, because we know that they help our asthma patients, can be very helpful to our asthma patients. Okay, so this is just kind of going through. So there's actually a lot of studies in COPD that are currently going on. So dupilumab now being actually approved, but actually mepolizumab, mepolizumab is now has a positive readout of their studies, and there's several other biologics that are now on their way to at least having readouts this year. So both IL-5 related, so the eosinophil, and dupilumab, which is IL-4, IL-13, and then tezepelumab, so TSLP, one of the alarmins, and I can say them off really fast. So I'm used to it. Itepekimab, tozorakimab, and astegolimab, which are the targeting the IL-33 pathway. So just kind of to go through some of that data. So initially, these studies, so there were actually studies of both mepolizumab and benralizumab, phase 3 studies done several years ago, and those are the ones, right, targeting the eosinophil, but they actually were studying groups where they were targeting lower eosinophil levels. So either 150 at screening in that MEPO studies, or 220 and above in the benralizumab studies. And these studies seem to have actually pretty mixed results. And one of the metrics actually showed a positive result for mepolizumab, but I think otherwise kind of flat. But what they were really seeing is that, as we kind of have been showing all along for our inhaled corticosteroids, that the higher eosinophils go, that maybe those subgroups may be the responsive groups. And so, like I said, mepolizumab actually just read out as positive. We don't have the trial data back yet, but hopefully we will soon. And so that would be exciting, because then you might actually have another therapy for COPD, but it's not peer reviewed yet. Dupilumab, however, now has 2 studies out, and I am a co-author in these studies called Boreas and Notice, but we're very similar. You need 2 studies through the FDA, phase 3s, to really get them to approve, as we learned from lebrikizumab in asthma, where one was positive and one was negative, and now there's no lebrikizumab for asthma. So reminder that dupilumab is IL-4 receptor blocker, so it's targeting kind of a broad swath of type 2 inflammation. And what they were looking at, so here, they're targeting blood eosinophils greater than 300. So, why this one worked and the other ones didn't, Is it because it's targeting a slightly different type of inflammation? Is it because they're just using the EOs greater than 300? I think we're going to learn that as more of the other phase 3 trials with EOs greater than 300 readouts. So I don't know the answer. We can all just be hand wavy. But the other kind of important parts of this that we think about, certainly almost everybody was on triple therapy. You could have it could be excluded if your physician said it was contraindicated, but it was only like 1 or 2% of people. And everybody here also, they were trying to, I think, enrich for a type 2 population. So everybody had to have chronic bronchitis. Other phase 3 trials are not including that, but this one did. So, and of course, no history of asthma. Whether they actually had asthma or not, I do not know, but nobody told them they had asthma. They weren't being treated for asthma. So at least this is what they're treated for. And I'll just skip some of this stuff just so we make sure that we end on time. But I think kind of importantly, what we see is that there's exacerbation reduction, 30% in Boreas and 34% in Notice. And there's an improvement in FEV1, and that actually happened pretty quickly. So it happened at about 2 weeks. So, you know, when I'm thinking about how this affects my patients, I am kind of hopeful that I might start seeing a response somewhat early, although, you know, an exacerbation may not happen until like a winter month or something. So I usually tell people, I don't want to take you off of it right away if you don't feel better, but that I am kind of expecting in the first few months that you may start to feel something. The one thing, so Boreas showed improvements in all of the kind of other clinical outcomes that they looked at. So meaning symptoms, in particular, Notice didn't quite reach significance, but in the pooled analysis it did. And then just thinking about the alarmins, and again, I think the only reason I brought this up was that there's a lot of preclinical data showing TSLP and IL-33 may actually affect broader groups of people than just our type 2 biology. But it's been somewhat interesting clinical data. So this is data from the course study, which I was a co-author on as well. And really, so it was a small study, so phase 2, meaning that not powered necessarily to show that you're going to get exacerbation reduction, but it gives us some ideas of what might happen in a phase 3 study. And what was particularly interesting here for an anti-TSLP, where in asthma, we use it to target both type 2 and non-type 2 high or non-type 2 asthma. And for COPD, what we're seeing is it's pretty clear that it does not work in patients with low eosinophils. In fact, there's some step diagrams that were very, very clear. It's like no effect if less than 150, and started having an effect if greater than 150. And we're also seeing that with the FeNO levels, which is another good biomarker of type 2 inflammation. So it always makes me think, hey, is there actually maybe more that, you know, asthma just has spillover, and that a lot of these people not type 2 high actually do have some type 2 inflammation in their airways. And so maybe that's what's happening. Or maybe tezepelumab is just a broader swath of the inflammation, and we're just getting the overall hyperinflammatory effect. Now, these 3 are the other 3 big ones in COPD, targeting the IL-33, and they've had some kind of mixed phase 2 clinical results that are all kind of interesting. But all thought that they may target a broader swath of COPD patients. None of them are including an eosinophil cutoff, so that's kind of exciting. So that we may actually have something that targets inflammation more broadly. And they kind of have these interesting mixed results where like the itepekimab seems to work better in subgroup analyses in former smokers. Tozorakimab seems to work a little better in the greater than 150, and ascolimab seems to work better in the lower than 150. But I think the reason I bring all of these up is that it does look like over time we're going to have kind of a if all these work, that we may have a broader group of patients that we might be able to treat with biologics. So we may have more options than just dupilumab, certainly, and certainly more than triple therapy. So it is kind of an exciting time thinking about endotypes. So that was it for me. And just to kind of wrap up, so we certainly see evidence based on a lot of our biomarkers on type 2 inflammation playing a major role in some patients with COPD. everyone with COPD. And that, the omics techniques that we use is really kind of to help us really understand some resolution a little better, potentially to find better non-invasive biomarkers down the road that maybe do a little better job than the eosinophil, but we'll see. And exacerbation heterogeneity, I think, probably plays a role in how we are responding. And I do think that maybe there's some of these groups that are not just not eosinophil high, but have something else happening in their airway, maybe even immunosuppression that's going to drive their response. And that there's multiple biologics that I'm actually pretty excited that we may have some better treatments for our patients down the road. With that, I think that is it. And this is my group. We definitely have a lot of trainees that work here, that work with us, that have done a lot of really great work. I work with a lot of the consortiums too, like in particular Stromics. So we've got a really great group of people. Thank you.
Thank you so much. That was amazing. A lot of information, a lot of things to process. I'm opening for questions. Yeah.
Thanks so much. Given the heterogeneity of responses, what do you think these interventions are actually doing?
I think it's a really good question. Really good question. I think.
I'm just to back off a little bit. We have inflammation of some flavor. We have a mediator of some flavor. We give a drug, then there's a clinical outcome. Seems like there's a little gap there in terms of like having some idea of like what's actually happening to understanding. And I didn't know whether you thought or what we're doing to fix that gap.
Yeah, like I was thinking, and that's one of the reasons I kind of brought up the mucins. Like in asthma, they actually show that you can, with the biologics, that they can reverse some of those plugs actually pretty quickly. Like we don't have that data in COPD yet, but could there be a role like for mucus plugging? I also wonder, seeing some of those responses from the biologics that happen somewhat quickly, and like, is there actually an airway, like a smooth muscle, we're decreasing the inflammation and helping with, but I think honestly, we're gonna need more studies to look at, kind of more translational studies looking before and after drug to see, hey, what is actually happening, what's happening at an imaging level, maybe what's happening at biomarker level, because I think you're right that there, especially in COPD, there's a lot of gap there. We could be hand wavy about it, but we don't completely know.
Dr. Christenson, excellent talk. So I'm sort of curious in terms of like all the work you've done on IL-17, Th2, do you think patients exist along an axis where there's like, okay, you could be more IL-17 or more Th2, or do they exist where like everyone could be anywhere along each of those, right? So you can be combo Th17, Th2, or some are only Th17. Like how are these pathways working within a given patient, and how can we use sort of that understanding to target or use multiple biologics?
Yeah, in asthma, there's actually some like good data on like, oh, it seems to be like a really polarized response, and right, like you treat the type 2 inflammation and then they polarize over there's like some thinking that they polarize over to a more neutrophilic state. In COPD, it's not quite that black and white. Like I do see patients that do seem to have like a mixed phenotype, and that's one of the questions that I'm hoping to look at in that COPD OMA study where, are there some of these people who look like maybe they're type 2 high, but they actually also have a lot of other type of inflammation in their airways. And so I'm not treating, the major type of inflammation in the airways. And so that it's not going to work. I think, you're talking about a complex patient group. So I think maybe there's a little bit of both. But yeah, I don't think it's quite as cut and dry as there's this one person has this and that one person has that. And we see that also with the emphysema data. Like, so the emphysema data in Boreas and Notice, which granted is not very good, but patient reported or physician reported emphysema, and that the drug still worked in patients with physician-reported emphysema and those without. So it's not working on the emphysema, but that patient population, they obviously have something going on more than just type 2 inflammation. If it's, I'm still not chalking their emphysema up to type 2 inflammation. I'm not so sure that I buy that, maybe, but we're certainly seeing some of these patients who look like they maybe have both emphysema or something else happening, and they're still getting a response to a biologic targeting type 2 inflammation. So little real world data too.
Hi, thank you so much. Really exciting to see some treatments coming forward for a disease that's not had any action for a long time.
Right?
So that's really exciting, and I think part of the problem has been heterogeneity, and so it's great to start to be targeting that. I have a question about asthma COPD overlap and whether or not there really is an asthma COPD overlap. And I started thinking about this with the initial dupilumab in COPD New England Journal trial, and there's just so much misdiagnosis of COPD. I have many patients come to clinic telling me that they have COPD and they really have all of the features of asthma.
Right, totally.
And I have had patients who technically I was under the impression of COPD, but they were eosinophilic, and I started them on Dupixent, and they were magically better to a level of suspicion that I was like, was this COPD the whole time, or was this a component of asthma as well? Do you happen to have allergies also? Yeah. So what is your thought about that? Is there a spectrum between asthma and COPD? Is there a point of long-term uncontrolled asthma that becomes phenotypically more similar to your chronic bronchitis COPD person? Like where, and maybe are there multiple sort of phenotypes in the overlap syndrome as well? What are your thoughts?
Yeah, I always think it's always a very interesting question to me because I don't know the answer. Like I think now Gold is saying we just call it asthma and or COPD, and we don't call it an overlap syndrome or condition or something. But I will say, like I'm never sure completely. You've got some of these patients who are really, man, they're acting like asthma, but they were heavy smokers. And there's certainly some severe asthma patients, right, who are, maybe they never smoked, but they are really acting like a COPD patient. And I guess I'm a little bit more interested, especially now that we're starting to get biologics for both diseases, in, okay, well, what can I actually, what's their biology, and what can I actually potentially treat? And certainly, as we get a bigger group of potential treatments, hopefully for both, that, we'll have multiple options, but that might be a group where I'm like, hey, I don't know, so I'm going to choose the drug that actually treats them both, which is the same thing we do in asthma, right? I think somebody might have, could they have some hypereosinophilic syndrome? I'm going to treat them with an anti-IL-5. So I kind of think of it, I try to just switch it on its head because I'm never sure, and I'm like, could all these patients just be a chronic asthma? I don't know, maybe, but I'm but I'm going to treat their disease, and it seems to help. So,
thank you very much. You, I think, spent a little bit of time talking about maybe a neutrophilic phenotype and some of those pathways. And a few months back, James Chalmers was out here talking about his, and I think this week in the New England Journal of Medicine, he published the phase 3 results of that work in bronchiectasis. I was just curious if there's anybody looking at the DPP1 inhibitors in COPD.
I think it's currently the earlier stages. Everybody always is at I feel like all the companies are asking about, hey, what do you think about this thing? And so I feel like some of those things are definitely in the pipeline. I also wonder if maybe because the IL-33s, maybe people are trying to see how do those ones play out, because are they going to actually treat I think we'll get a little bit more information as some of those read out. Are there going to be some potential overlap where we're actually getting at some of that? That's just my guess. I don't know where the pharma companies are thinking though.
We have a last question here from anybody else? Oh, sorry, Natalie.
Your boss.
Can I bring this? Can I bring this one from the? Okay. So Jacinta, one of our asthma nurses, she's asking, is it a problem that COPD exacerbation is defined as change in dyspnea, cough, sputum in a COPD patient, that a significant portion of COPD exacerbations are related to viruses, bacterial processes, and we have no therapy that will prevent patients either COPD or otherwise from being asymptomatic when infected. Can we ever truly prevent exacerbations in non-eosinophil mediated flares?
Yeah.
That's a very good question.
It is a very good question. And, like, I'm never completely sure, like, how much, if tamping down some of that inflammation with like an inhaled corticosteroid over time, or at least tamping down some of that, smooth muscle reactivity, certainly that we know that alama-LABA decreases exacerbation risk, right? So we know that that's important. Is actually some of that inhaled corticosteroid actually helping tamp down like interferon responses in certain groups? I'm not exactly sure. I just know that it doesn't work in those patients with the really EOS low group. And I don't know if that's just because there's so many people that just don't have that, like, any like mixed inflammation, is there like a group that has some mixed inflammation in the higher group? This is why I really use, after those studies, I do use a lot more inhaled corticosteroids in my COPD exacerbation-prone COPD patients. But I think it will be really interesting over time as we get more data on like exacerbation heterogeneity. Like, are there groups that, hey, maybe I need to be using azithromycin and getting your hearing test done once a year and checking your EKGs, or maybe there's so maybe there's groups that are more like that versus or using a DPP1 that's targeting neutrophilic inflammation, and I think that'll be or one of the biologics, so I'm hopeful we're going to find more, and that maybe now even with industry more excited about COPD, that they'll be more excited about helping us get some of these answers.
So this is a fascinating talk, and I do have one comment, which is now that we actually have drugs going on, we need to have simpler names. So we should follow the cardiologist, do a TIMI, because all these names don't make any sense anymore, and I cannot remember them. Right?
True, right? I just get to say them all the time, so now I remember them all.
But so we need something like TIMI, right? Whenever like we go from 1 to 67 or whatever it is. Now, so the question which I think came up is the question: can you really reprogram the immune response? So if you really treated very early COPD, would you really shift their behavior? Because I think there is clear evidence that you're doing it for the chronic. Right. So do you think, are there any people doing these kind of trials?
Yeah, so I don't know that the trials are being done. It's a huge topic right now in COPD research. So we have in Spromics, we have our the source study, which is like a sub-study of Spromics, where we're actually pulling out much younger patients, like I think we're going to 40 to 55, and Beacon in the UK is even a little bit younger than that. And of course, we've got the lung health study too. We're really trying to follow these patients like earlier to really understand what does disease progression look like? Where can we maybe intervene for disease modification? Because you can't do a clinical trial in like thousands and thousands of people just to see who's going to have lung function decline over time. You need to like actually maybe have markers of like who's going to be that person, so that we can actually pick the right patient population and pick the right like intermediate markers. So I think I feel like for us, we're like still pretty early in that. To me, it feels very early in that process, but it's kind of the holy grail. Like, we really want that disease modification. So.
Thank you.